Instagram Live. Hi guys, this is like a bit of an impromptu sort of quick hello. So we've just finished a sort of a 2-day spinal manipulation course here at the London College of Osteopathic Medicine. This is Ian. Hey guys, how you doing? Now Ian is part of the teaching team. You might have seen him on some of the videos, but so what we thought we'd do is we've literally just done this 2-day manipulation course, and we thought we'd just have a little chat about how that's gone and some of sort of like the common issues that some of the students had whilst we were teaching. Hey, in Vietnam, man, how you doing? So the basic level 1 course, we were sort of covering CT, thoracics, lumbars, sort of the bread and butter sort of techniques that we would use in clinical practice. So from me, someone who is sort of teaching sort of new grads in manipulation, one of the big things I would always say is it's like less is more. There's a big emphasis for students when they get into sort of manipulation to try and do too much too soon. Like with the online academy, we've got like 170 techniques, right? It's just massive. So what I would always say is it's about breaking down the common techniques that you're going to use in clinical practice, getting really good at those and then building upon it. So like getting a really good sort of solid foundation, not trying to rush too much. And especially when you're getting into clinic and you're using these techniques in clinical practice, I would always say sort of less is more. Only use what you need to. Don't sort of overcomplicate the treatment by chucking in millions and millions of techniques. All right, so keep it simple. Less is more. Now, what I was going to say, Ian.
That was one of the questions that got posed quite a bit, was how many manipulative techniques can you carry out in one session?
Actually, to be fair, that's a valid point. So like when you look on social media, like I see it all the time, you'll see like patients getting cracked from like the OA to the hallux. They'll get manipulated absolutely from head to foot. Is it valid or is it not? I'll ask you, does more manipulation mean a better therapeutic outcome, right? You know, you're a teacher, you're a lecturer, you're going to be a physio very soon. How would you answer that question to a student? Does more manipulation mean a better therapeutic outcome?
More treatment of any sort doesn't mean a better therapeutic outcome. It goes back to what are you like looking to evoke for the end of that treatment session. So what is the therapeutic outcome you wish to achieve by the end of that 30, 45, 60 minutes with that patient? So what have you screened for? What have you tested for? What are you seeing that is present with that patient? And what kind of positive change do you want to evoke by the end of that session? So that may be just by simply increasing quality and quantity of movement through the thoracics, or, you know.
Do you know what? Actually, one of the big, like being honest, one of the biggest mistakes I made as a new graduate osteopath is because I love a bit of technique. I really do. I would, if you were my patient, I would sort of manipulate you from head to foot, right? I would literally crack everything. And that was ego. That really was my ego. And I think I did a post a while ago. You really need to think about leaving the ego at the door. Only do what you need to elicit the outcome you're trying to achieve. So if that means you only need to do sort of 1 or 2 techniques to sort of elicit the sort of symptomatic modification, the pain reduction. If you only need to do 1 or 2 techniques to try and change the mobilization or the functional modality, that is, in my opinion, much, much more effective than trying to smash the person from head to foot. I actually found I would get better results when I brought my treatments back. So if I was doing less, I could gauge what the patient was doing, how they would respond. And actually I found I would get better results. The more I did, the more chance of hyperstimulating the patient there would be. They'd either come back going, that was amazing, or they'd come back going, I was absolutely battered. So for me, I think it's about choosing the right technique for the patient, having flexibility to adapt those techniques, only doing what you need to. Yeah, only using the techniques you need to elicit the outcome that you're trying to achieve. What I was going to ask you, what did you find was some of the most challenging things for you when you first started using manipulation?
Rushing the setup more than anything else.
Yeah.
So not taking the time to really work on building the foundations, i.e. your foot placement, getting your own biomechanics, getting the table height sorted, rushing into trying to get that manipulative technique, hear that crack too soon. Because when you rush the setup, then you're going to probably miss the technique or cause some.
Do you know what? Actually, this is the irony, right? Setup and biomechanics is so important. I was chatting to the students today, right? When you look at how much power is needed to manipulate, actually it's not as much as you think. So if you want to crack the thoracic spine, you need around about 500 newtons or about 50 kilograms, right? Because you've got to factor in the ribs, you've got to factor in other issues. The lumbars, and now bear in mind, when you watch social media, you'll see people like shoulder barging the lumbar spine, smashing the lumbars. You actually only need about 400 newtons or 40 kilograms of pressure to manipulate the lumbar spine. So you actually need less power to crack the lumbar spine than you do to manipulate the thoracics. Yet when you watch people, they put so much power into the technique that it's almost, there's a very fine line between treatment and torture. You know, it's like Hulk smash. I don't think you need to use that much power to get an effective technique. And what Ian's talking about is when you get the setup right, when you get your biomechanics right, so that's taking your time. So look at the table. Is the couch the right height for you? Is the patient in a good position? Are you biomechanically effective? Are you using your levers? If it's just brute force and you're trying to smash the joint, you are going to come unstuck. You'll get away with it for a short amount of time, but you'll end up compromising your own joints or your fatigue. The idea is the more biomechanically effective you are, the more gentle the technique, the easier it becomes. So absolutely, new grads, like Ian was saying, right, don't rush this. Don't chase the money shot. don't chase the manipulation, right? What I would say is take your time. Don't rush it. Set the person up and look for that barrier. If you've put someone in a position and you don't feel like the joint's locked, then don't go through with it. Reposition them and put them back into a position where you do feel that bind. What do you do about bigger patients? Look, you shouldn't have a problem treating or manipulating people of any size. This is all about adaptation. So for example, if I have a patient who is like massive and I want to do their lumbar spine, I might not be able to do a lumbar roll. So I would adapt that technique, either do it seated, using the hips to lock on the pelvis and do a low manipulation that way. I might do a supine rolling manipulation, trying to manipulate the upper lumbars. It's all about adaptation. This is one of the problems I see actually. If you only have 5 techniques, then you literally are absolutely screwed when you have a patient that comes in and you've got to adapt. Manipulation, like we put like 170 techniques up on the online, it's all about adaptation. Making sure that you're not compromising your biomechanics, but also choosing a technique that is going to be suitable for the patient. Like if you've got a massive person, the last thing you're going to do is do a lift, because it's just like it's brute force. So you would change that, maybe do it prone, do it side lying, take a lot of the pressure out of the technique for you. Actually, one of the tips I was always trained in as a student, you be lazy. Be the laziest therapist you can be. Now, what I mean by being lazy, it's about being biomechanically efficient. So when you look at people in the gym and you look at someone doing like an Olympic lift, when they are biomechanically efficient, it's smooth, it's a good, clean process. When they're using brute force and power, it's really hard, it's jagged, it's not pretty to watch, and it's really difficult to do. So biomechanically effective, biomechanics, take your time and you're good to go. What other stuff? So we talked about position setup. What other stuff did you find problematic?
Breathing, working with the patient's breathing in yourself and aligning your breathing with theirs. Works for any technique, as we'll need to be working with the patient's breathing, but more so for thoracic techniques and rib techniques. As we breathe in, they're breathing in. As you breathe out, you know that they're almost, the tidal volume is at its most minimum, and then there's less pressure in the thoracic cage, which makes that technique a lot smoother for yourself. It's
funny actually. I mean, firstly, you want your patients to be breathing, because if they're not, they're dead, and that's a frowny face. But when I work with manipulation, for me, breathing is probably one of the most important parts of the process. as the patient breathes out, I breathe out at the same time, because I'm sort of gauging at what point they're about to take their breath back in. Because as soon as they breathe back in, then everything is starting to fire off. You want them to be the most relaxed they can be. And at the point of exhalation, the body will sort of naturally relax. And I think it's a really important timing to actually get in sync with the patient. So I love watching dancers, you know, those sort of like ballroom dancers, right? No, seriously, right? When you watch ballroom dancers, they're like in sync. They're sort of moving in sync.
It's fluid.
It's freaking beautiful, man. It's lovely. When you watch two people that, like, if Ian and I were to try and dance, right, it's gonna be really difficult. It's gonna be horrible. And that's the same with manipulation. If you can get in sync with the patient, right, breathing, timing, position, the manipulation will actually start to become really gentle and really fluid. If you're sort of almost fighting with the patient and it becomes really blocky, that's when you actually have a real problem. Any book recommendations for manipulation? Dude, we've written 2 books on manipulation. Don't take the mickey. You can literally just click onto Amazon and you can buy one of our books. There's loads of books out there. We've written a couple on manipulation. There's some really good chiropractic ones out there as well. I would always say, especially with manipulation, open your mind, osteopathic, physiotherapy, chiropractic, look at all professions and really get an idea. Don't worry too much about the philosophy. Just have a look at the technique and you can fit that into your treatment process. What do you mean?
If you do not get the manip on the first try, do you try again and risk failing on the second manip?
Right, so with manipulation, I would always say you get 2 shots at it. Personally. So for me, I would try the technique. If it didn't go or I hadn't had that change I was expecting, I may then try a second time. That would be it. From a personal perspective, I don't think you should just keep hammering the joint over and over and over. I'm okay with it. And also remember, you don't necessarily need to hear the click. It's fine. You put the thrust into the joint. If it goes, it goes. If it doesn't, it doesn't. Test it, treat it, retest it, and if you've had tangible change, high five, tier medals, everyone's a winner. Don't force it. But I've made the mistake of having a patient come in and I've tried to manipulate something, it hasn't gone, I've taken it as almost like a personal insult, and then I've tried again and again and again and again and again. You finally get it, but at what risk? What risk to the patient? At what risk of causing sort of excessive hyperstimulation? So for me, I would say, have a go. If it doesn't go and you haven't had a change, you've got rationale to try again, and then leave it at that. Go above, go below, use a different modality. Because remember, manipulation is not for everyone. There's a question on about sort of medication. I ask my patients not to be taking sort of pain meds or excessive anti-inflammatories before the treatment. The reason why I ask them not to take it is because I really want to sort of see what their realistic pain levels are like. I find if they are taking loads of pain meds or anti-inflammatories, when you're trying to examine or trying to look at the tissues and stuff, you can get sort of a misrepresentation. So I always ask my patients to try not to take too many pain meds or something before they come in. That way I can at least sort of see realistically what they're like. I also don't prescribe medication. I always say to my patients, look, go to your GP, go to your pharmacist. If you're going to take meds, whatever it is, get advice. So as an osteo, we don't prescribe in that respect. Yeah, so it's pretty straightforward in that front. But how would you say? Would you use more than 2 techniques, or?
Depending on the patient. If it didn't go the first time, or I didn't feel comfortable the first time, I may totally strip it back, readjust and reset up that technique, or I may totally change the technique. So thoracics, for example, maybe going at a prone spring. If I'm not too comfortable with that, maybe change it.
Do you know what? I actually don't mind. I've put patients in the position, and this is the thing, I've put patients into a position to manipulate, and I've just not felt it right. I've just thought, do you know what? It just doesn't feel locked, it doesn't feel right.
It just doesn't feel...
Yeah, and when I was a younger therapist, I almost felt obliged to manipulate because I've put them in the position, I've spent the time. Nowadays, I'm sort of big enough and ugly enough, I'll go, do you know what? Let's try something else. And I'll actually say to the patient, no, I want to put you supine, seated, sideline. I may position them 2 or 3 different ways until I feel that the technique is appropriate and right.
Depending on the severity of the patient's conditions, if they're acute, chronic, high levels of pain.
I would actually say
too much.
Yeah, I mean, I would always say when you've got patients that are acute and chronic, my treatment process tends to change a little bit. So if they're coming in and they're really, really acute, I do as little as I physically can. I won't do loads of work. Do just enough to get the result I need and then get them out. And if they're really chronic, it's been a long-term process, then I might have to do a lot more work. I would say choose your techniques appropriate to the patient. Acute less, chronic more, in its very basic of senses. I was going to say something else then, but I can't remember. What was I going to say?
Almost touching on the setup and moving through too fast. I completely forgot what it was as well.
This is the thing. Would you
back.
ever use manipulation to end off a therapy session for the feel-good effect, or is it always a precursor to it? Well, actually, you make a valid point, man. Ironically, as an osteopath, when we were trained at university, it doesn't matter what the patient came in with, we would go sort of soft tissue, mobilization, manipulation. It was almost like a bit of a standing joke at the end. And I think using manipulation as a crescendo to a treatment just for the effect, I don't think is appropriate. Personally, that would not be I would only use manipulation for a therapeutic outcome and a therapeutic benefit. I'm manipulating an area to elicit specific neurophysiological responses to try and then do some form of exercise rehab. Cracking a joint at the end of it just for a feel-good factor is, I don't think is appropriate in clinical practice, to be honest. I don't think you should use manipulation unless you have a reason to. Otherwise, you end up basically being like one of those hairdressers that just fucking cuts the hair and then cracks the person from head to foot. You have to have a thought process. Then this actually is one of the big problems when we were teaching the students over the last 2 days. Why are you wanting to crack this area? What is your clinical rationale? Why you're not doing it just to make them feel better? Because I might as well just give them a freaking, give them a sugary drink or whatever, then give them a sugar rush. Why am I wanting to crack something? What is my rationale? How am I then going to reinforce that treatment process? What exercises, what education? What is your thought process? Why are you using the technique for this person in this area? So you really need to have a good understanding as to what it is you're trying to do. And I would always say with manipulation, it's not about how to crack a joint, it's knowing when not to crack a joint. That actually, I would say, I don't know about you as a teacher, but I always say the most important thing when you're learning technique is knowing when not to do it.
Yeah.
That's key.
Kind of touching on that question there. What about migraine patients, chronic patients, and when you can't see consistent progress? When you can't see consistent progress, that's when you may need to stop and refer either to a colleague that's maybe got more experience than yourself.
Do you know what? Don't be afraid to refer. I think a lot of the time with patients, we keep our patients and we don't want to let them go. We sort of just hold them tight. It's my patient,
It's the ego thing as well.
Yeah,
not
ego.
asking for help.
Listen, ego is massive in our profession. I think you have to be big enough and ugly enough to go, listen, I've tried, I'm not sure why we're not getting progress here, and have the confidence to refer. Now, I'm an osteopath, but I work with chiropractors, I work with physios, I work with other osteopaths. I think it's really important that you make good links with other professions. And if you've got a patient and you're hitting 4 or 5 appointments and you haven't got any real consistent progress and they're doing everything you're asking, have the confidence to say to them, look, see my colleague, let's reassess something, let's see how things go. I think, because ultimately it's not about your ego, it's about the patient. It really is all about the patient. And if you can't help them, refer them to someone who might be able to look at it from a different perspective or give something different. Have the confidence to go, have the confidence to say, I can't treat you. Have the confidence to say no, and have the confidence to refer, because ultimately you won't come unstuck. If you try and do everything, you're going to end up coming unstuck at some point. So I would always say, have the confidence to refer to a colleague, to be honest. What else? Chronic pain. Yeah, chronic pain's a nightmare. Do you practice classical osteopathy? No. I don't. Look, for me, as an osteopath, I'm very MSK based. I like MSK. I don't do classical technique, as in I'm not just cracking junction points and doing protocols. I also don't do cranial technique and I don't do visceral technique. That's not part of my scope of practice. I'm very much MSK based as a professional, and I believe that, I'm not saying those things aren't effective, but if you want classical osteopathy or those sort of modalities, I'm a big fan of going, look, go and see someone who specialises in it. Just like if you want really good S&C, go see Ian, S&C coach. He'll be able to help you there. So don't try and be a jack of all trades. You know, it's good to have an understanding of different modalities, but be open-minded to refer. I can treat pregnant patients, but I work with some really good midwives, really good people that have done special training with pregnant patients. So for me, I tend to refer. And then you get this reciprocal process going, and that's really key. Working with other professions in the industry, it's really, really important. While doing minutes, what should we focus on? Okay. Look, ultimately, for us, in regards to manipulation, it's talking about dangerous. There's danger in everything. There's danger crossing the street, there's danger in massage, there's danger in acupuncture, there's danger in manipulation, right? Every therapeutic modality you do has danger. There's danger taking freaking ibuprofen. There's danger taking an aspirin. There's danger taking an over-the-counter opioid. The key thing is about doing a thorough case history. Do a really good case history. Make sure that you're safe. Make sure the patient is safe to treat. That, for me, is absolutely fundamental. And I do think a lot of people skip the case history. I think a lot of people don't do a thorough enough case history and spend enough time asking pertinent questions. They sort of tend to rush the case history and just get straight into treatment. 80% of your diagnosis is done through case history. The safety part of your treatment is done through case history. Question everything. Write it all down. Make sure you write stuff down, because if you don't write it down, it never happens. So for me, that is probably one of the most important parts. Again, it all comes down to protecting you as a practitioner. Cover your arse and write stuff down. How do you manage patients' expectations of outcomes? That's a really good question, actually. I'll answer it after Ian has answered it. How do you manage patient expectations?
Not just from manipulation.
Yeah, I was going to say, this covers all modalities.
From the very start. For me, it comes straight back down to discussing what we're there for with that patient during the subjective assessment and setting out their end goals for the end of that that treatment session itself. So it goes back to what we were saying 5-10 minutes ago. What are the outcomes that we are wishing to seek by the end of that appointment? And then that's when we kind of start to come into how we manage patients' expectations, because they might, we get those patients that come in and say, "I seen John, the osteopath. He done X, Y, Z. I've been seeing them for 6 months, and they want you to go down the same road." You need to limit their expectations in that, they might not be progressing as quickly as they want to. It might be quite a chronic condition that they've been suffering with for a number of years, and you need to strip it back with that patient and educate them correctly in the manner that, what we're going to be doing in this session is a very small percentage of the overall plan, 5-10%. The bigger aspect of this is the exercise rehab plan, getting you back out, moving more and moving correctly, and then stripping back the expectations from there. So we're going to try and regain some quality and quantity of movement, get a reduction in pain symptoms by the end of the appointment, but the longer process, getting you back to moving without pain, getting you moving back with better function, is going to take a longer period of time. So for me, even before we move in past the objective assessment, past the treatment process, within that consultation, I'm setting the patient expectations straight away during the subjective assessment as we're chatting through their signs and symptoms in their case history.
I think there's two things here with patients. When we're looking at manipulation, the key thing is letting the patient know that a crack is not necessarily going to happen.
Or a golden bullet.
Yeah, it's firstly, when I manipulate an area, I turn around and go, look, it may or may not manipulate. You may or may not hear a click. Doesn't mean it hasn't been effective. We test it, we treat it, retest it. If there's been change, improvement, reduction in symptomatic modification, happy days, we move on. If the patient is obsessive about hearing a click, The problem is if you don't get that, then they're going to think the technique hasn't been effective. So for me, when we look at those sort of modalities, patient expectation is getting them to understand that we might not always hear a cavitation, and that doesn't matter, okay? That doesn't matter. Otherwise, I might as well just put bubble wrap underneath it. When it comes to treatment overall, managing patients' expectations is really important, especially these days, because we live in a society that is a very quick fix society. So everyone wants everything done now. Fix me now. I want to be pain-free now. I've seen someone on social media do a technique and I'm 10 years pain-free now. Patients can have an unrealistic expectation of what the treatment process is going to be like. So for me, I say to the patient, look, could take anywhere between 4 to 6 sessions, depending on whether it's a long-term problem or an acute problem. You are going to have good days and bad days. Do not expect this to be a quick fix. We're going to have slow, gradual improvements. For me, it's about saying to the patient, look, I want you to improve by 1% every day. If we can start creating lifestyle changes, nutrition changes, exercise, we can start building in these other aspects of biopsychosocial factors around what we're doing. Maintain consistent, gradual improvement. Don't expect massive quick fixes. Or listen, everything you see on social media with these gurus fixing someone's frozen shoulder in one appointment is nonsense. All these miracle cures is nonsense. It's about slow, gradual progression, good, solid improvement, creating that tissue resilience, the education, the confidence in movement, understanding what they're going through. That is the expectation I need to get across to the patient. And ultimately, if they're looking for a quick magic fix, I'm very open and say, look, you're not going to get that. I can help you in the short term, manage your pain a bit, but ultimately I need you to be doing all these other things so that we can, over time, create self-resilience, self-reliance, and then ultimately you look after yourself and you only see me on a semi, sporadic basis. So it's very important you get that across. Otherwise, patients, if they're expecting miracle cures, it's very difficult. Plans for Singapore. Look, at the moment travel is really restricted. So this month, at the end of the month, I'm in Germany, we're in Bosnia, next month we're in Italy, and then we might be in Sweden, and then India. November with Rohit will be hopefully in India. But again, it's all down to travel restrictions at the moment. It's very challenging, but we are hoping to be sort of back there sort of internationally as much as we can. For those of you that can't access the face-to-face stuff, we still have the online stuff. So you can access and work with us all via the online academy. There's loads of stuff. We're actually putting a load of more free stuff on there as well. So make sure you check it out. I'm going to be posting a load of videos from the last 2 days over the next sort of week or so. And feel free to drop us any questions you've got, and all gravy. But anyway, listen, guys, can physio students attend the course? Yes, you can. Ian's going to be a physio. We work with physios. I'm an osteo. We work with everyone, so don't fret. Right, guys, it's Friday. Have a great weekend. From Ian, say goodbye.
Thank you.
I will say goodbye. Any questions, feel free to DM us, and we are out.